So I'm going to be talking about certain cases where, again, we don't exactly see what's going on without having access to an aberrometer. So the first case is that of a 41-year-old radiologist who presented to us with a progressive deterioration in vision and an increase in myopia. He didn't have any other complaints. There was no significant systemic history. He was referred by another ophthalmologist for this progressively increasing myopia and astigmatism in the right eye, and he was currently on treatment with lubricants. His examination findings, apart from an increase in the myopia, there was nothing else really significant. The anterior and the posterior segment seemed perfectly fine, and he was actually getting corrected to a best corrected of 6/5. Now, when we looked at our investigations that we normally do, we looked at Pentacam, which showed an absolutely normal value. There was no significant astigmatism also in the Pentacam. The OCT also revealed an absolutely normal macular OCT. So with this in mind, we started ruling out our various differential diagnoses that we think of when there's an increase in power. We ruled out keratoconus because of the Pentacam being normal and a regular astigmatism. We ruled out primary open angle glaucoma because there was no sign of that. Macular pathology was ruled out because it was a normal OCT. Axial myopia, the age was against this. There wasn't any clinically significant cataract when we looked at the slit lamp. And we also ruled out accommodative spasm because normally that is a bilateral condition. When we looked at the eye tracy in this patient, what we actually saw was an increase in the aberrations. Now, the good feature of the eye trace is that it splits the aberrations into corneal, internal, and total. And what we found here was that basically the aberrations, the total aberrations were being mainly contributed by the internal aberrations, and the cornea was actually quite okay. When we looked at the wavefront analysis, again, this tells you where the astigmatism is actually coming from. And you can see these two maps that correlate are the total and the internal, again, showing that this is predominantly a lenticular astigmatism, which is contributing to the poor quality of vision in the right eye, as can be evidenced with the point spread function in the eye trace as well, which shows a scattering coming from the internal optics. When we looked at the dilated RMS, again, there was an increase in the higher order aberrations. And one very useful feature of the eye trace is the dysfunctional lens index. This gives you a scoring. Anything less than 6 is significant. And what we saw was a scoring of about 4.13 in this patient. So though there was not a clinically significant cataract on slit lamp examination, there was significant what is called a preclinical or Zernike cataract, which was affecting the contrast and probably contributing to an increase in myopia. With this in mind, this diagnosis was made, and the management was that the patient was referred back to his primary ophthalmologist with the above diagnosis. The primary ophthalmologist called me later to say that the cataract surgery was performed and the patient's complaints were completely resolved. We've also seen preclinical cataract masquerading as post-LASIK regression, which we have published in the Oman Journal of Ophthalmology when I was a fellow at Narayan Nethralaya. Another place where the eye trace is very useful is for measurements of accommodation. It actually gives you a more objective measure of the accommodation. You can turn on the monocular or binocular open field option and correct both the refractive error to measure and give distance and near targets to actually measure the amount of accommodation that the patient has. So this, for example, is a patient whose difference between the distance and near refraction is showing a good amount of near accommodation. The second case that I'd like to discuss is that of a 33-year-old female patient who came for refractive surgery. Normal findings again. She underwent a PRK, left eye followed by the right eye. It was an uneventful course, immediate post-operatively, but after about 10 days, she came with a decline in vision in the right eye, which was about 6/12. It was an uneventful surgery. There was compliance with medications and no haze, so we didn't know what was explaining the poor vision in this patient. When we saw the epithelial profile, the epithelial map in the right eye was showing a little bit of epithelial irregularity. So we thought this probably explains why this patient is having these issues. Along with that, the aberrations on the Pentacam again showed higher post-operative aberrations, probably contributed by an irregular epithelium. So we decided to do intense lubrication, gel-based formulations at bedtime as well, and to follow up the epithelial healing. Now, on day 21, the situation became a little worse because along with the right eye, the left eye also showed a drop in vision. Still everything looked fine, and we went back to our epithelial mapping, and in fact it looked a little better. In both eyes, the epithelial mapping looked fairly regular at 3 weeks. So what was causing this issue? When we looked at the eye trace, and performed a cycloplegic refraction, in this patient, you can see the E chart significantly improves post the cycloplegia with atropine. So that actually was showing what is called an accommodative spasm. Now, the treatment for this is to put the patient on either atropine or cyclopentolate eye drops for a few weeks, let the accommodative spasm break, and then generally the patient recovers well. So this is another case where the aberrometer played an important role in us coming to a diagnosis. And again, we have published this role of aberrometry in accommodative spasm after myopic PRK. The eye trace also helps us to decide on certain cases where you want to put a multifocal or not. Now, it's important to understand that the visual axis, the optical axis, and the pupillary axis don't all coincide. So the visual axis is nasally decentered, and therefore there's the angle created between that and the optical axis called the angle alpha, and between the visual and the pupillary axis called the angle kappa. Values which are greater than 0.5 in this generally are a contraindication for multifocal IOLs. And you may have a patient, if you put a multifocal IOL, they may not be particularly satisfied. Again, this is not a hard and fast that you have to go by angle alpha, but it is another thing that we usually do preoperatively in our multifocal patients. Another place where the eye trace helps is for customizing IOLs because there is a positive spherical aberration from the cornea, which is generally balanced by the negative spherical aberration by the lens. It's preferable to leave a small amount of residual positive spherical aberration for enhancing depth of focus. So the eye trace has this function where it tells you the spherical aberration in a particular zone. So for example, in this patient, it's about plus 0.28 microns. And generally in this case, you would use a negative spherical aberration lens, which is not something like an Acrosoft IQ, which will give a slight positive spherical aberration to help with the depth of focus. So these are some of the cases that I just wanted to highlight. These are my acknowledgements. Part of the work is done when I was a fellow at Narayan Nethralaya. Part of it is from Shroff Center. Thank you.